Morning, everyone. Continuing with the last week's presentation, giving a brief summary of the last week's case. Our patient was a 26-year-old primary gravida who had presented with history of right flank pain with fever, with chills and burning micturition. And with a past history of having detected right renal cyst on follow-up. On clinical examination, she had...
skip all this. Just go ahead to where we were last time, the ultrasound and ultrasound onwards.
We had done, discussed ultrasound, sir, then MRI images I was supposed to show,
yes,
sir. Shall I open the MRI, sir?
Yeah, sure.
Is it visible, sir?
Yes, it is.
Hardik, sir, can you see the images?
Yes. It is T2 axial imaging of MRI showing high signal intensity the right upper and interpole region with a multiple septed cystic lesion over the right kidney. With a mildly dilated right upper ureter with a normal left kidney and ureters.
If you don't hear anything from our side, Hardik, you have to keep going on. You can't wait every time. Okay, so now you have seen the images, you have to go on. What do you think? What do you want to do?
It is, sir, a 28-year female, sir, with symptoms of fever, flank pain, and burning.
No, all that we know. See, we finished all that, isn't it?
Yes, sir.
So you made some diagnosis on ultrasound. You wanted to do an MRI to confirm. Now the MRI has been done.
Yes, sir.
So proceed from there. You gave us the description. What is your conclusion?
Yes, sir. So my conclusion is 28 years female with...
No, that's not your conclusion. That's all history. What is your conclusion? Don't go back again.
Sir. So, sir, I will admit this patient as...
diagnosis by? The patient will say, why are you getting me admitted? Give me medicine and send me.
Yes, sir. So, a report, please.
No, they'll show you the report. Wait. But you've seen this. What are the possibilities?
Sir, it is based on the Bosniak classification. This is a type type 3 cyst, sir.
Type 3 cyst. What is the differential diagnosis?
Yeah.
See, when you get somebody who presents with fever and these features, the main thing is to differentiate between an infected cyst and an abscess. Correct? You already said
Yes,
it is not hydronephrosis.
Yes.
Fine. So
Yes.
is it an infected cyst or is it an abscess?
It is infected cyst, sir.
Why is it not an abscess?
Sir, it will if abscess, then it will be area of, sir, hypointense signal inside that cystic area.
Why should it be hypointense?
It is a, sir, thick collection. So in T2 it will.
It's a T2 weight. See, abscess need not necessarily be thick collection. How do we determine whether something is an abscess or something is a cyst, or it is just infected, or it is infected hydronephrosis? Not just infected hydronephrosis, infected hydronephrosis. These are the three possibilities.
Yes.
Anybody wants to take this?
Hardik, let me make it a little easier for you. What are the CT findings of an abscess?
You can answer that question if you know what an abscess will contain. And then work out from basic principles as to what it will show when you highlight it with nothing and with contrast. You cannot highlight it with nothing, but when I say with nothing means with a plain CT. And then when you put contrast, what will happen?
Sir, contrast will not uptake by abscess.
Does an abscess have a capsule in the kidney when it's an abscess? Does it have an outer covering?
No, sir.
No.
Sir, in CT it will be.
Most abscesses are contained unless they are intraperitoneal or something, diffuse peritonitis. But most abscesses in the body are contained. You have a lump on the skin, it's contained. You have something else, it's contained. So it's all well contained. What does it contain? Does it contain dead tissue or does it contain live
dead tissue?
Dead tissue, right.
Yes.
Is it vascular or is it avascular?
Avascular, sir.
So now,
when you get an abscess on the skin, does it appear red when it's pointing, or does it appear like the rest of the skin, or pale?
It appear like red, sir. Like
why does it appear red?
Due to inflammation, sir.
What happens in inflammation to make it look red?
what happens if you incise an abscess which is not yet ripe on the skin? You've done it sometime, no? You may.
Yes, sir.
It tends to bleed more than
yes.
one that is absolutely ripe and ready to burst and sort of burst onto the skin, isn't it? Yes.
Yes, sir. Early for
work it out. How will abscess in the kidney look? You heard of lobar nephronia?
Yes, sir.
You can get renal abscesses also.
Is there is a sir? It is a stage between the acute pyelonephritis and the abscess lobar nephronia. In that, it is a wedge shape, collection is seen in the kidney in early forming type abscess, sir. If we will not control lobar nephron, it can progress to the abscess, sir.
The point you're missing here, Hardev, is all
sir.
of us want to know how will you differentiate between a cyst, an abscess, and hydronephrosis when you've done a plain scan. A plain scan will not help you do that. You need to put in contrast. You do a contrast scan, and if that shows features of inflammation like increased vascularity, edema, and so on, then you know it is inflamed. So if it is inflamed, it's either inflamed cyst or it is an abscess. How do you differentiate these two? We started there. Think about it. We'll move on. We'll come back to this later because it has certain implications.
Yes.
Yeah, ask whatever you want.
Next.
What's happening, guys? None.
Shall I show the report, sir?
He said next. So you show him whatever comes next in your slides. No, we won't confuse him with all that. Just go to the report.
Okay, sir.
There are interesting things, but might not be for a trainee urologist.
We rarely see MRI images in pregnancy. So, first look at that.
Can you
Is a
see,
mid-
sir?
Yes. It is multiseptated cystic lesion predominantly in the mid-pole of right kidney, measuring 7.5 into 6.5 semi with Bosniak type 3 cyst and mild hydroureteronephrosis secondary to the compression of the mid-ureter by the gravid uterus.
In pregnancy,
sir,
which part of the uterus is at the greatest risk of compression?
pelvic brim, sir, ureter at the pelvic brim is the greatest site for compression, sir.
Okay. Yeah, let's move. In a manner of speaking and for discussion, it's much better to avoid this upper, lower, and mid-ureter business. Instead, you can call it the lumbar ureter, the iliac ureter, and the pelvic ureter, so that we know at what level the lesion seen or obstruction seen is. Because something might be upper for radiologists, something else might be upper for urologists. And among urologists, again, there can be differences. So the portion of the ureter that lies between the pelvic-ureteric junction and the pelvic brim is the abdominal ureter of the lumbar ureter. What lies across the iliac bone is the iliac ureter. And as it emerges from the pelvic outlet to join the bladder is the pelvic ureter. This is something which might be more convenient. Dr. Ganesh, your impression?
Hardik,
Sir.
Dr. Mohan asked you about the compression of the ureter, and you said at the pelvic brim. Is there any reason why it is more on the right side than on the left side?
Sir. It is written that right side is more common than left side, sir.
Okay, it is written like that. But is there any reason why it is like that? I
There
also
must be an anatomical or physiologial basis for that, isn't it?
Yes, sir.
So why is it more on the common on the right side? That's the question Dr. Ganesh asked. It is not random. There is a reason. What is the reason?
Since you don't know, I'll tell you the answer because it's sometimes important for us to also reveal the truth. The truth is that there is, in maximal number of patients, the dextro rotation of the uterus, along with the enlargement and impinging on the pelvic brim, it rotates to the right. So, therefore, there is a much more higher chance of the right side being involved. Okay, that's the reason.
Yes, sir. So, sir, this is Bosniak type 3 cyst, and sir, 28 years female with a fever and flank pain. I will admit the patient and start on the intravenous parenteral antibiotics, sir. Third generation cephalosporin injection, ceftriaxone, and see for the response whether patient is responding to the antibiotic or not. If fever and pain subside.
Okay, we understand you, but tell me, you think that this lady's urinary infection is just one of those conditions which happen more frequently in pregnancy, or is it related to this swelling? You think the swelling caused the infection, or just the pregnancy caused the infection, which is more common? You know, people get UTI in pregnancy. What's your take on this? You've seen the images, you've seen everything else, you've seen the report.
Sir, it is like UTI in the pregnancy because, sir, in MRI images, it does not show any abscess formation. So, if patient is not responded, then, sir, it's better to put the double J stent.
Don't go so far. Don't go so far. What are the routes by which infection can reach the kidney?
What is so difficult about that?
Sir, it is more common in pregnancy. Patient have bacteriuria.
Question is, how does this infection reach the kidney? Simple. How does the infection reach the kidney in any individual? I presume it is any individual, not necessarily pregnancy.
Through, sir, hematogenous route and ascending infection through the ureter, sir.
By and large. Anything else?
And also, sir, in pregnancy, there is a increased level of progesterone leads to the smooth muscle relaxation of the uterus and stasis of the urine. That leads to more chances of infection.
We are asking at even a more basic level. If bacteria have to reach the kidney, by what routes? You said it can be a retrograde route. You said it can be hematogenous. Dr. Ganesh is asking you, is there any other route by which bacteria can reach the kidney? Yeah, anybody?
From the direct involvement from the adjacent tissues, like port spine.
Like?
Say port spine.
You'll have to speak louder, Kamal. Can't hear.
Sir, from the adjoining tissue, sir. If abscess is in the adjoining tissue or liver abscess, it can directly involve the girotas or kidney, sir.
I couldn't hear from what tissue.
Network is little poor, sir. I am saying from the adjoining tissue abscess can come to the kidney.
Right. What adjoining tissue?
Sir, like lumbar, port spine, or from the liver.
Port spine? No, you're going too far. Something which happens more often.
Psoas abscess, sir.
Sorry?
Psoas abscess, sir.
Why should, okay, you're again going up the wrong path. Let us see. You always, when you present a patient with infection, you say no history of constipation, no history of constipation. Why do you say that?
So from bowel, sir, transmigration of bacteria from bowel can go to the obstructive system or
So, adjacent bowel is also a source of infection where the migration happens not through blood but across the tissue barriers.
yes, sir.
Got it, Hardik?
Yes, sir.
Don't forget that, it's very important. We discussed this some time back. I told you about diabetic who had recurrent UTI and had to have colostomy post-transplant simply because his bowel was loaded all the time.
Yes.
So this is a real problem. All these children, all these patients who have dysfunctional voiding, neurovesical dysfunction, one of the main sources of recurrent infection is the stool. That is why the base procedure and all that is done, no?
Yes.
Yeah, so. Don't forget the lymphatic route also, okay?
Yes.
Yeah. Okay.
Yeah, I think case
sir.
is in your court.
So Hardik, you started on antibiotics and she did not improve.
Sir, I will explain to the patient that you have a infection in the kidney in form of maybe pyelonephritis and high chances of complication in form of the premature labor, and it is complicated to the mater and fetus also. So we have to put a double J stent into the right ureter under the.
You're not jumping the gun here. Tell me how will leaving a ureteric stent or introducing a ureteric stent drain infected cysts?
Sir, but in MI it is not showing, sir, any abscess collection or sign of inflammation, sir, in that cyst.
Where does the stent go? Where is the upper end of the stent?
It is in the pelvis, sir.
Right. And what is connected to the pelvis? What drains into the pelvis? The calyces drain into the pelvis.
Yes, sir.
Correct?
Yes,
What
sir.
is the difference between, how do we differentiate on imaging between hydronephrosis and cysts?
In hydronephrosis, it is communicating with the pelvis, sir.
Yeah. In cysts?
It is a separate collection. It is not communicating with the pelvis.
It is a separate structure, correct? So now if you drain the pelvis, are the cysts being drained?
No, sir, no.
So where will the infection go away then? How will it go away?
Sir, she had a right upper side hydroureteronephrosis also. Maybe
That's
that
okay.
gravid uterus compressing and
That's okay,
that causes pyelonephritis feature. So better directly put.
Universal made the diagnosis of infected Bosniak type 3 cysts. And we saw no reason to disagree with that. In the differential diagnosis, you might have other things. Now, if it was anything to do with the urinary tract itself, we presume antibiotics should have taken care of it because that's how it's treated in pregnancy. We don't stent every patient who shows hydronephrosis or hydronephrosis with UTI, right?
Yes, sir.
So here, let us accept your diagnosis. These are infected cysts. So what do we do to treat the patient?
Sir, I will put percutaneous drain into that cyst, sir, nephrostome.
How many cysts are there?
How many drains will you put?
Multiple separated, sir. So it will not drain.
How will you confirm that actually the cyst is infected?
So, sir, first I will do aspiration and then material I will send for culture sensitivity and see the content. It is a serous or sir.
How do you know which cyst you are going to puncture? There are so many.
A diagnosis has been made. Your consultant has said, aspirate the cyst and send it for culture. Which cyst will you aspirate? How will you decide which cyst to aspirate?
if this cyst was really infected, wouldn't you see some other features on the CT or the MRI which suggest that the area of the tissue around the cyst are actually